Bonding in orthodontics. Why bonding matters. Orthodontic bonding is one of those procedures that looks deceptively straightforward. Place the bracket, shine the curing light, and you're done. But in truth, every detail, from how long you etch, to whether a drop of saliva touches the surface, to which adhesive system you choose, determines whether that bracket will hold for 2 years or pop off in 2 weeks. In this masterclass, we'll move beyond the basics. We'll look at the full science of bonding, discuss adhesives, light sources, and bracket types, and most importantly, connect it all to real clinical cases. Because bonding isn't just a technical step, it's the foundation of every orthodontic treatment. History and evolution. Before bonding, orthodontists relied on full bands around teeth. Imagine cementing a metal ring around every tooth. Bulky, plaque, retentive, and uncomfortable for patients. Everything changed in 1955, when Buonocore introduced acid etching of enamel with phosphoric acid. This breakthrough created microscopic porosities in enamel that allowed resins to grip mechanically. By the 1970s, direct bonding became practical in orthodontics, and it revolutionized our field. Today, fewer than 5% of brackets fail in most practices. But that number only stays low if we respect the biology and chemistry behind bonding. Step 1. Cleaning. The first step is deceptively simple. Clean the enamel. A pumice prophylaxis removes the pellicle, that thin protein layer covering enamel, as well as plaque and debris. Why does this matter? Because resin cannot bond to plaque. It needs direct contact with enamel. Skipping this step is like painting over a greasy kitchen wall. The paint peels off in days. But caution is needed. Don't traumatize the gingiva. Even a small bleed contaminates the field and compromises adhesion. This is especially important in partially erupted teeth, like second molars. 2. Moisture control. Moisture control is where good bonding succeeds or fails. Saliva, blood, even breath condensation, all can ruin an etched surface. We have many tools, cheek retractors, dry triangles to block the parotid duct, suction devices, tongue guards, cotton rolls. The choice depends on the tooth location and the patient's salivary flow. Think of moisture like oil on a road. Even a thin invisible film can make a car skid. In the same way, a drop of saliva can destroy the microporosities created by etching. Case example. I once saw repeated bond failures on a lower molar. The culprit? Saliva contamination during etching. After adding a tongue guard and high-volume suction, the rebond held for the entire treatment. Step 3. Enamel conditioning. Enamel etching with 35–37% phosphoric acid for 15–30 seconds remains the gold standard. Properly etched enamel appears frosty white. But here's the nuance. Cervical enamel often looks different from incisal or central enamel. Don't re-etch just to make the appearance uniform. Over-etching removes unnecessary enamel. Self-etching primers, or SEPs, combine etching and priming in one step. They are quicker, but evidence shows slightly higher rates of white spot lesions, especially in patients with poor hygiene. For now, conventional phosphoric acid remains the most reliable. Remember, if the etched surface is contaminated, rinse and re-etch briefly. Never bond on a contaminated surface. Analogy. Etching is like sanding wood before gluing. You're creating micro-retention. If the surface is wet or oily, the glue won't hold. 4. Sealants and primers. Once etched, enamel is porous and vulnerable. A thin layer of sealant or primer fills these micropores and improves resin penetration. There is debate about their absolute necessity. Some argue they improve bond strength, others say they mainly reduce microleakage. Moisture-insensitive primers, like Transbond MIP, are particularly helpful in tricky cases: half-erupted molars with gingival bleeding, impacted canines after surgical exposure, or areas where saliva control is impossible. But, and this is key, hydrophilic primers are not a free pass for sloppy technique. They tolerate minor moisture, not contamination. You still need discipline. Step 5. Bonding procedure. Now comes the heart of the process, actually placing the bracket. 1. Transfer. Grip the bracket with tweezers, load adhesive on the base, and transfer to the tooth. 2. Positioning. Use a scaler or placement guide to adjust mesiodistally, vertically, and in angulation. 3. Fitting. Press firmly to seat the bracket fully. This pushes resin into the mesh and avoids voids. 4. Excess removal. Before curing, scrape away excess adhesive, especially gingivally. Why is excess a problem? Because resin left near the gingiva traps plaque. Within weeks, you'll see gingival swelling or decalcification halos. Clinical Pearl. Teach patients to brush around brackets from day one and prescribe daily fluoride rinses. Adhesives. Adhesives fall into 3 main groups: no-mix adhesives, quick but less studied for long-term strength. Light-cured adhesives, the workhorse, strong, flexible, and allow unlimited working time before curing. Glass ionomer cements, weaker bonds, but release fluoride. Useful in high-risk caries patients. Choice depends on patient needs. For most routine bonding, light-cured adhesives with composite resins remain the standard. Analogy. Think of adhesives like glues. Some are strong but fussy, light-cured. Some are forgiving but weaker, glass ionomer. The trick is knowing which job needs which glue. Light sources. The adhesive is only as good as its cure. Light curing activates polymerization, and the light source matters. Halogen, classic, 20 seconds per bracket. Plasma arc, ultra-fast, 3-5 seconds, but expensive and hot. LED, efficient, cordless, minimal heat, now the gold standard. But remember, light must match adhesive chemistry. Using the wrong light leads to incomplete curing. Case example. A resident cured ceramic brackets with halogen for only 10 seconds. Half failed in a week. Once proper curing time was restored, failure rates dropped to near zero. Brackets and surfaces. Brackets differ in material and behavior. Metal, strong, predictable, easy to debond. Ceramic, aesthetic but brittle, high friction and difficult to remove. Plastic, aesthetic, weak, used mainly for short-term adult cases. Gold-coated, an aesthetic compromise, less plaque retentive than ceramic. Bonding to restorative surfaces requires special protocols. Porcelain Me sandblast plus hydrofluoric acid plus silane. Amalgam Me sandblast plus metal primer or 4-meta adhesive. Gold still unpredictable despite strong lab data. Analogy. Bonding to enamel is like Velcro on fabric. Bonding to porcelain or amalgam is like Velcro on glass. You need primers to make it stick. Indirect bonding. Indirect bonding allows precise positioning of brackets in the lab, then transfers them to the patient with a tray. Advantages: accuracy and shorter chair time. Disadvantages: technique sensitivity, risk of voids, slightly higher failure rates. Indirect bonding is particularly valuable in lingual orthodontics, where direct vision and access are limited. Common failures. Bond failures usually come from technique errors, saliva contamination, inadequate etching, moving the bracket during curing. Prevention is better than repair. Every failure means rebonding time, patient frustration, and extended treatment. Excess resin is another hidden problem. Left along gingival margins, it causes plaque accumulation, gingivitis, and eventually decalcification. Case correlation: a teenage patient developed gingival swelling around lower premolars. On inspection, excess resin had been left at bonding. Removal of resin plus hygiene instruction resolved it in weeks. Conclusion: bonding in orthodontics is not just about sticking brackets. It's a discipline. It requires understanding enamel biology, mastering adhesives, controlling the clinical environment, and never cutting corners. Every successful bond is a silent partner in your patient's treatment success. Respect the details, and you'll prevent failures, save chair time, and deliver better outcomes.